Hi, I'm Dr. Carmen Puliafito, and I'm here today with Professor Anat Loewenstein, who's the director of the Department of Ophthalmology at the Tel Aviv Medical Center in Israel. And welcome, Anat, to Retina Synthesis.
Thank you so much, Carmen, for this kind invitation. I'm very thrilled to participate in that.
Uh, we're here to talk about your presentation at the Angiogenesis 2021 meeting, Home OCT Monitoring of Neovascular AMD. So Anat, tell us a little bit about your presentation. It was fascinating.
Thank you so much. It's really I'm excited to see that this specific presentation, among all these exciting new drugs and everything that you showed, you found it interesting. So basically, what we were able to show is that there is a fully integrated home OCT system that can be used by subjects that have neovascular macular degeneration. And it can be used by them at home, be installed by them, and they're able to capture gradable images that are mounted on a cloud and evaluated by artificial intelligence technology to see how much fluid they have and the dynamics of fluid. Along with this, we propose a novel reporting parameters of the temporal dynamics of the retinal fluid volume, something that was not shown before, at least not in that manner. So we're talking about, it is an investigational system that looks at only at the central 10 degrees of the macula, but we found out that more than 95% of the lesions are there. And the activity is there, and it has automated data transmission ability to a cloud, and artificial intelligence-based analyzer algorithm, the NOAA, provide the fluid quantification, and the system is actually based on this. So the NOAA is looking at the B scans, is doing what the box does, and then provides segmentation of these B scans and provides a fluid report map that has a fluid thickness map and a temporal graph that shows what happens with the patients. We already presented the technology many times in the past, but what we presented here was actually the first time that longitudinal data was presented, because in all the previous studies, what we did was a home mimicking environment in the office, but now actually we provided the patients with the ability to self-install the technology and to capture their own images. They were supposed to use it for a month on a daily manner. Patients were not young. They were all above 70 years of age. Mean age was 74. And basically, most of them were able to provide gradable images. And not all of them, but most of them were able to provide gradable images. And it's not for everyone, but even very elderly patients are able to use the technology. And this is actually also very reassuring that even very old patients can use the technology. And actually, their performance improved with time. So with time, first of all, the time was shorter per eye. It's very short. It's about 40 seconds per eye, all during this short-term everyday study. And then more than 90% of the images were had acceptable quality that could be graded. When we looked at then the NOAA grading of these self-captured images mounted by a cloud and compared them to human graders, then the agreement for all fluid, intraretinal fluid or subretinal fluid, was very, very high. It was all more than 93%. For intraretinal fluid, which we know is the most important, it reached 97%. And we were able to provide the fluid thickness maps, and also for subretinal fluid, for intraretinal fluid, and for the total amount of fluid. And when we looked at the DICE coefficient comparing human graders and the NOAA, it all gave excellent results. That show that it is at least comparable. And also, when you look at the graph that in Pearson correlation graph that compares human graders versus NOAA, also it was almost a diagonal line of 45 degrees with the coefficient being more than 0.99. And what was nice, I think, is that we showed some cases longitudinally, showing exactly what happened. So some of them have a immediate decrease of subretinal fluid for when we started the follow-up, and then you can see when it reaches a peak, and the great response of the fluid 2 days after giving the injection. Or another patient that had different dynamics, that there was at least stable fluid at the beginning, stable fluid at enrollment, and then there was fast response to treatment with very good, really complete resolution. Some people had initial subretinal fluid fluctuations and then a stable growth until it reached a path. Another nice thing was that we could show that some patients had, let's say, some intraretinal cysts that at the beginning we couldn't say if it is active or just an atrophic cyst. Later on, when we saw that it's exactly the same all over the time, with and without treatment, you can actually detect if it's active or not. So I just think that we were able to show that we can show some different nomenclature for fluid dynamics because of the daily follow-up of the patients. And we proposed some new definitions, such as fluid presence interval, fluid free interval, and so forth. So all of this needs to be, of course, discussed and further investigated.
Well, it really provides an opportunity to get new information about the dynamics of treatment, because really
Exactly.
you're monitoring patients in a way that they've really never been monitored before. And,
Exactly.
and what do you think about the potential of this really as a research tool and not simply as a clinical monitoring tool?
I think it's really very exciting as a research tool, because you can know about various drugs or various technologies, especially now that we are talking about long-term technologies. So in the patients that can get either a specific drug, they can hold 3 months. So what happens when they approach the 3 months? What happens exactly daily around the time when they need treatment? And it actually can also provide like a real PRN system, because you know exactly when to treat. In some of the patients, you can see that the patient actually got the fluid coming back 2 days after he was in his treat and extend visit, where according to what was seen in the treat and extend visit, he could be further extended. But a day later he had fluid, so maybe it needs to be looked at differently. So it's definitely a new way to evaluate the performance of new drugs and technologies.
I'd like to talk a little bit about the device itself.
Mm-hmm.
How good vision do patients need to have to use the device?
Well, yeah, they do need to have some quite a good, I mean, they need to have some vision, but we had patients that were 20/320 and could still use the technology. So it's not because it's not functional. They don't need to perform, to do anything. They just put their head in. Of course, if they're NLP and they cannot find the device at home, it cannot be used. But yeah, but it can be used over a wide range of visual acuities, and also in a wide range of ages. And it's quite user friendly.
So are both eyes scanned simultaneously, or is it one eye at a time?
One eye at a time.
One eye at a time,
And it's about 30 to 40 seconds per eye.
and the patients know that the scan is complete with an auditory signal. Is that how it
Right.
works?
Yeah.
And how large is the system?
It's small. It's like like I would say it's more like a small laptop computer or something like that.
How far away are we from being able to buy this system?
So actually, it's not positioned to be bought at all. It's actually positioned to be let to the
Right.
patient, rent. Yeah, the patient is going. It's not something that you'll go to the pharmacy and
Right.
buy. It's something that you'll get a prescription from a physician. A physician will send it to the clinical center that the company has. They already have a lot of experience with the PHP, so they have this clinical center, and they will distribute the device to the patient's homes with the prescription of the physician, and the physician is responsible and reimbursed for the fact that he has a patient in the system and for the fact that he's overviewing the data. So he will have access to the images 24/7, but will get an alert when there is, and his assistant can get the alert, everyone can set it the way he wants, but the physician is in charge and he is reimbursed for that too. And actually, I think it's not far. It's it's waiting for FDA approval, and it's not far from being able to be used. It's already going to be implemented in multiple big pharma trials.
How do you think this will be used in clinical practice? Which kind of patients will you be using this in?
I'll tell you, I think that if you have a patient that that needs treatment monthly and is getting treatment monthly and he cannot cope with any other thing, maybe it's not so useful for him. But if there is a patient that that you want to extend and that you want to monitor in a way that he doesn't need to come to the clinic when it's not an injection day, then I will definitely have them use the technology at first. And then later on, maybe all the patients.
Mm-hmm.
So, also for now, most of our studies are for AMD, but we already have data for DME. So, it's only a matter of resources, but I think the company will also look at other disease processes.
In many of these patients, they had dry disease in one eye. How does this compare to PHP in terms of sensitivity detection?
It's totally different. It's like comparing apples and oranges. I think that for CNV detect, it was not looked at and compared in terms of sensitivity, but I think that for detection of new CNV, the PHP is the right answer. It has been proved for that. It has been studied. There is all the science there that shows that it detects the CNV earlier than symptoms. So for that, it's excellent. Yes, if a patient is monitored for one eye for treatment and you will develop a CNV in the other eye, the Home OCT will also detect it, but it was not compared to the PHP.
Okay. Well, listen, thanks so much for your time. And
thank you. Thank you for this exciting invitation. It's an honor for me, Carmen.
Thank you. Thank you very much, and have a good day.
Thank you. Have a good day. Bye-bye.
Bye. Bye.